Next session is going to be on the update on systemic therapies for atopic dermatitis in the adolescent population. It's going to be given by Dr. Vimal Prajapati. And Vimal, you're on.
Awesome. Okay, great. Thank you, Dr. Chuck Lind and the rest of the organizers at Dermatology Update. You folks put on a great show twice a year, every year. And I'm sad that I couldn't be there with you folks today in Vancouver, but I am here in Calgary. And we're about to get a snowstorm in the next 24 hours. So I really do wish I was actually in Vancouver. And we'll get going here because I know you folks are itching to hear my presentation on atopic dermatitis in adolescents. And today we're going to talk about targeted systemic therapies. And it's a very exciting time to be a dermatologist, as you folks know, who treats atopic dermatitis. And it's also a very exciting time to be a patient who has atopic dermatitis, just because we have so many amazing treatments available. And in the adult population, some of these have been improved. And in the adolescent population, we do have an approval for one of the medications, and we should be getting more approvals over the next few years. Feel free to ask questions in the chat. I am monitoring the chat, and I'll just get the next slide, please. And that's just the program disclaimer that these slides were provided by Sanofi Genzyme. And we'll move on to the next slide. And those are just my speaker disclosures. We'll move on to the next slide. So today's goal is actually to discuss the burden of atopic dermatitis. We're going to have a specific focus on adolescents. And then we're also going to talk about Dupilumab, which is the blockbuster medication that we've had at our disposal now for several years in the adult population and recently now in the adolescent population. And then we'll answer some questions and answers at the end. Okay, good. Move on to the next slide. And we'll move on to the next slide. Good. So you folks know atopic dermatitis is actually the most common chronic inflammatory disease that we see in the pediatric population in industrialized countries. And the prevalence ranges between 5 to 20%, but this is variable. And we do find that in industrialized nations, the incidence and prevalence of atopic dermatitis is higher. The age of onset, we do see a lot of children less than 5 years of age that have atopic dermatitis. 85 to 90% of all cases of atopic dermatitis will happen before 5 years of age. With that said, there was some data presented at many conferences over the past few years, which did state that adults actually can have new onset atopic dermatitis in about 25% of cases. So back in the day, we used to tell patients that typically you grow out of eczema, and once it's gone, then it doesn't come back. And if you're an adult with eczema, maybe it's not actually atopic dermatitis because it should only happen in those who are children, and it eventually stays with you when you're an adult. But that's not true. There are new onset atopic dermatitis patients that we do see that are adults. And severity, we do say 10 to 40% of all pediatric cases are moderate to severe. I'll move to the next slide. I think this is probably one of the most important slides in this whole deck, and that is that atopic dermatitis has a huge impact, not only on the patients, if they're adults, but with the pediatric patients, the caregivers. And I think a lot of the issues happen because not only are the pediatric patients burnt out from having to put all of these medications either onto their skin or taken internally over the years, but the adult caregivers are also burnt out. And this shows that atopic dermatitis has actually the second largest impact on quality of life, only second to cerebral palsy. And you can see that actually atopic dermatitis, if it's moderate to severe, is actually higher in terms of impact on quality of life versus psoriasis, which is another condition that's listed on here, and urticaria. So there are a couple of other skin conditions on this list, but atopic dermatitis actually is the most in terms of impact on quality of life. And so that's something very important that we have to address when we talk to families of pediatric patients or even the adult patients, is how much does your atopic dermatitis or eczema, as I say, bother you? And I always ask that question, and then I wait and I listen to what either the adult caregiver has to say regarding their child or the adult patient has to say regarding themselves. And on average, people will talk for maybe 15 to 30 seconds max. Sometimes you get a talker and they might go on for 90 seconds, but it's very important to actually just listen to the patients and hear their story. And ultimately, some of the goals or the targets that we have come out in that discussion. Next slide, please. And so atopic dermatitis, we know that it affects the skin. Pruritus is a huge issue. Also, they've noticed that pain can also happen in the setting of atopic dermatitis, sometimes due to fissures. But this also has impact on other parts of the person's life. And sleep disturbance is a huge problem, as are mental health issues. And as someone who sees a lot of children and adolescents with our pediatric practice that we have, the issue here is that these problems have to be addressed. And I always ask about the impact that atopic dermatitis has on the child's sleep, since today's lecture is focusing on adolescents, and also impact on mental health. So anxiety, depression, embarrassment, low self-esteem, all of these problems can actually happen. There was a study done, presented at a conference several years ago, that said in a child who has very severe atopic dermatitis, that individual, if they have moderate to severe disease, may wake up actually almost 36 times during the night. And this is a huge problem, because if you have sleep disturbance, then you're also not getting growth hormone produced, and then you're not going to be meeting your milestones for height and weight. And we've seen this many times in our practice. Infants will come in and the parents will say, we're feeding the child everything that we can. They seem to be consuming it. For whatever reason, child is not meeting milestones for height and weight. And the pediatrician, or sometimes the family physician, has mentioned, failure to thrive in the referral that was sent to us. And what happens is, when we adequately control these individuals, eczema, and they end up actually improving, and their milestones for height and weight start to be met. And part of the reason is because their sleep improves. And the parents will say, yes, you were right. Now that the atopic dermatitis is under control, we've noticed a significant improvement in sleep. And now the child is meeting milestones for height and weight. And also those mental health issues, anxiety, depression, all of that actually starts to improve. So this is something we have to keep in mind. Other associated conditions, we all know that atopic dermatitis is associated with asthma and seasonal allergies. And then some individuals may not know, but you can also get eosinophilic esophagitis, and you can also get chronic rhinosinusitis with nasal polyps. And these conditions all are linked to the atopic disease. Move to the next slide. And so this is another very important slide, which shows you the impact that atopic dermatitis can have on sleep. And the graphic on the left there shows that if you categorize it by age, on average, if you have an exacerbation of atopic dermatitis, 44 nights out of a year are being affected in terms of sleep disturbance. And that's if you're between 2 to 13 years of age. If you're between 14 to 17 years of age, there's about 88 nights per year that is affected by sleep. And that's a lot. If you look at the slide graphic on the right, you can see that if you categorize by disease severity, for a patient with moderate atopic dermatitis, 33 nights on an average per year are affected by the atopic dermatitis, and the sleep impairment happens. And then if you see the severe atopic dermatitis, almost 162 nights per year. That's almost half the year that individual is not sleeping properly. This can have a huge impact on daily functioning. And it's very difficult for many of these adolescents and even younger children to function at school, because they are so tired that teachers will often comment that the child seems like they're not interested in any of their activities at school. Well, part of the reason is they didn't sleep properly the night before. So if I were the same person, I wouldn't be interested either in anything that's going on at school. And the second problem that happens from this is without the proper sleep, the children become quite fidgety during the day. And that sometimes is associated with attention deficit hyperactivity disorder, which actually has been linked to atopic dermatitis as well. So something to keep in mind, and always important to ask about sleep disturbance, whether the patient is an adult or they're a pediatric individual. We'll move to the next slide. And of course, school attendance can be impacted by atopic dermatitis, especially in this pediatric population. So they did a survey, the Eczema Society of Canada, which always does great work, and a quality of life insights project was done with 658 individuals involved. And of the 20% of patients who missed school, they said that 23% actually missed over 10 days of school, and 12% of individuals missed over 20 days of school. So now the atopic dermatitis is starting to have an impact on performance at school. And likewise, in the adult population, we see that it has performance for individuals at work. We'll move to the next slide. And this is actually a huge issue that happens in the pediatric population. And the problem is we can recommend all of these amazing topical therapies, and we have lots of them available. Obviously, topical corticosteroids are first-line therapy, but we also have non-topical corticosteroids available. And those being topical calcineurin inhibitors, we have topical phosphodiesterase 4 inhibitors, the topical JAK inhibitors are being investigated. We also have topical aryl hydrocarbon receptor agonists that are being investigated. So there's lots of targeted topical treatments that are coming out on the market. The problem is compliance and adherence are not necessarily high in individuals who have atopic dermatitis. And part of it is because of the burden that this disease has had on the family for the entire time that the child has had this problem. And the burden is not only on the child, but the burden is also on the caregivers. And many times there's a complete breakdown on both parties, and the child and the parent, neither wants to put topical treatments on. And so even though we know that if they just followed our instructions, the atopic dermatitis would be clear, we don't actually get clear skin. And part of the reason is because they're not using the treatments. And the study here showed that 80% of caregivers find treatment regimen challenging and have difficulty maintaining it. And we're talking about topical therapies specifically. And this is another reason why, because I see so many children and adolescents, we do about 125 pediatric patients per week with atopic dermatitis. Even during the pandemic, we've maintained those numbers of about 25 to 30 pediatric patients with just atopic dermatitis. And frequent follow-up is actually the best, because frequent follow-up puts the onus on the families to deliver and make sure that when they send us photographs virtually, or if they're coming to our clinic for in-person visits, they want to have the child's skin clear, because they know I'm going to scold them if the child's skin's not clear. And so this has been an issue where we have to do frequent follow-up to make sure they follow the protocol. But even some families with frequent follow-up, they just don't use the treatments, and they're not using it. At that point, then you have to have the discussion that we need to move on to other modalities, such as either light therapy or systemic therapy, because at this point, nothing we will give you topically is going to fix the issue. And at that point, the families actually have a realization, and many times pediatric patients, if they were a little bit hesitant to go on an internal medication, they also have a realization saying, you know what, you're right. This problem is really bothering me, and I'm not going to be compliant with these topical therapies. And so I'm open to trying light or systemic therapy. And at that point, it becomes easier to move on to the next modality. Next slide, please. So this is a wonderful slide. It's very busy, but what it shows you is that this is an exciting time for dermatologists who treat atopic dermatitis and for patients who have atopic dermatitis, because we have so many targeted treatments that are now available. And so we'll go through this slide. Obviously, today's discussion will focus on Dupilumab, which was, as many of my patients say, and I say myself, an absolute game changer for atopic dermatitis. And Dupilumab has been amazing for our adolescent patients that we have on this medication. They're all doing wonderful. They're super happy with the treatment. And even though there is sometimes a little bit of fear of needle phobia at the beginning, that needle phobia goes away very quick. When that child sees results and that parent sees results, and the fact that they're spending way less time on their skin, those people are happy. They're actually fine with a little bit of inconvenience that they have to do an injection that takes maybe 5 seconds to do. They're fine with it, because actually their quality of life is significantly improved. So interleukin 4 and 13 are inhibited by Dupilumab, so those are listed here. Dupilumab also does have an effect in studies. They've shown interleukin 31 goes down. And for you folks, obviously on the call, are educated on atopic dermatitis, interleukin 4 and 13 are the main drivers of atopic dermatitis. And also interleukin 31 plays a huge role with that, especially pruritus. And that's why another pharmaceutical company has developed nemolizumab. So nemolizumab is listed here that targets interleukin 31. And although Dupilumab is the only medication right now that's a targeted systemic therapy on the market for adolescents with atopic dermatitis, nemolizumab is being investigated in that population. So that's very good for you folks to know. And also, we have specific targeted interleukin 13 inhibitors that are being investigated in adolescents. So that includes tralokinumab and lebrikizumab. Some of the differences, Dupilumab is still the true treatment for the atopic diathesis. So Dupilumab works for atopic dermatitis. It also has efficacy in asthma, which has been demonstrated in studies in adults. And I'm sure the studies are coming in children soon. And in the other atopic more comorbidities that are there, We've had some patients actually with eosinophilic esophagitis, and I know that this is being investigated for that condition. But we've had some children followed by myself, pediatric dermatology and pediatric gastroenterology. And the pediatric gastroenterologists were very impressed because they didn't know that this medicine can actually help with that condition. And we had a few skeptical pediatric gastroenterologists. But in fact, when they did repeat endoscopies and they were doing follow-up, they were finding that the patients were actually doing much better, and the families were happy, the child was happy, and the other specialists involved in the care were happy. So when we talk about Dupilumab, even though there's other molecules coming on the market, this is still going to remain the true treatment for atopy. And that's atopic dermatitis, that's asthma, that's seasonal allergies, and also eosinophilic esophagitis, nasal polyps. So we always have to think of Dupilumab as being the gold standard for those conditions. We also have in the top left corner, you see there's molecules that are now being developed which block TSLP. And TSLP is important because they think that is actually the cytokine which is responsible for the atopic march. So the thought is that if you can deal with the atopic dermatitis early on in life, maybe you can prevent asthma and also seasonal allergies from developing later on. And the link might be TSLP. So we actually have a TSLP inhibitor that's being investigated right now in adults, and eventually, I'm sure, in children as well. If you move over to the right of the slide now, mepolizumab is an interleukin-5 inhibitor. It has not had super duper success with atopic dermatitis. It's more used, I find, by the respirologists. They have mepolizumab in their armamentarium, whereas us dermatologists do not use interleukin-5 inhibitors as much. And then we also have other molecules. So they've investigated interleukin-17 inhibitors in the past. It's not been a blockbuster, but I do find that some of those individuals that have a dermatitis and maybe a psoriasis overlap, you do a skin biopsy, they say psoriasiform and spongiosis that are seen. Those patients actually may do okay with an interleukin-17 inhibitor. I've had the most success with brodalumab, and I learned that from Dr. Jensen Young. He taught me that, in these individuals use brodalumab because it blocks interleukin-17C as well. This is something that is very important. And there's been an interleukin-17C inhibitor that's been investigated by one of the pharmaceutical companies, and it's shown some evidence that there's efficacy in atopic dermatitis. Whether or not that molecule is taken to the market is unknown, but at least there's some evidence there. Some people have investigated ustekinumab, an interleukin-12/23 inhibitor for atopic dermatitis. Again, there's anecdotal reports that it may help in some individuals, and potentially it's more of those patients who have that dermatitis psoriasis overlap. There's also an OX40 ligand inhibitor, and that's a product that's being investigated in adults and eventually children. Whether or not it gets taken to the market, again, not uncertain at this time. And then there's also interleukin-22 inhibitors. So fazakinumab has been investigated, and there's some thought that interleukin-22 can play a role in atopic dermatitis. One challenging population are sometimes the Asian patients who have this Th17 phenotype, and clinically it can be very challenging. You look at the skin and you say, yeah, it looks like atopic dermatitis, but I'm wondering if maybe there's psoriasis here. And you end up doing a skin biopsy, and those patients sometimes do show this overlap, and those individuals maybe using an interleukin-17 inhibitor might help. So those are just some pearls there. We'll move on to the next slide. Of course, there's a whole new class of molecules that's being investigated for atopic dermatitis, and I always joke that I'm jacked up about these just because of the fact that they're super targeted, and most of the other medicines that were mentioned actually on the previous slide are subcutaneous, and a few of them were IV, but this slide shows that we actually do have oral therapies that are more targeted and coming to the market soon. And so JAK1 inhibitors include upadacitinib and abrocitinib. JAK1 and JAK2 inhibitors, that's baricitinib, it actually blocks both of those. And then JAK1, JAK3 is tofacitinib, which has been on the market for a long time. Rheumatologists use it quite a bit. And I've been using it recently, but not for atopic dermatitis. I've been using it more actually for alopecia areata and vitiligo off-label. And it's been an absolutely wonderful experience with these JAK inhibitors for those conditions. I think for the first time in a long time, dermatologists will not mind seeing patients with alopecia areata and vitiligo because we can actually offer them something that works really well. I have children as young as 8 years of age that actually are on oral JAK inhibitors because the only tofacitinib is available right now for me commercially. I've put a bunch of patients on tofacitinib, and it's been wonderful. Complete regrowth of hair in alopecia areata. We're talking alopecia totalis. and universalis in some of these individuals, and also vitiligo. We've had complete repigmentation. It's been amazing. And then delgocitinib is mentioned here, but this is actually a topical therapy, and it's a JAK1, JAK2, JAK3, and TYK2 inhibitor. So it does all of those. I think with the JAK inhibitors, they're going to be very fast. In fact, they may replace systemic corticosteroids and also systemic immunosuppressives like cyclosporin. And these medicines will be extremely effective for atopic dermatitis. The issue is going to be compliance. So anytime we give a tablet in dermatology, we think our patients are listening to us. Most likely they're not. And they're going to have issues with these medicines not being taken on a daily basis. And so it's going to remain to be seen once these molecules are on the market. If we were to have patients only do maybe three times a week dosing or weekend dosing, they only do it 2 days a week, is there going to be a flare-up? And if we need to then get them back under control, do we just go back to once a day and all of a sudden their atopic dermatitis is under control? Another issue with these molecules, the oral JAK inhibitors, is going to be laboratory test monitoring. So the nice part about Dupilumab is we don't have to do any of that at baseline or follow-up. Whereas with the oral JAK inhibitors, we will have to do baseline as well as follow-up laboratory monitoring. And specifically with JAK1 inhibitors and JAK2 inhibitors and JAK3 inhibitors, we do have to monitor for cytopenias. We have to monitor for dyslipidemia. We have to monitor for elevated serum CK levels. And those will come up as we go along. Also, we will have to monitor for elevated liver enzymes. These can all happen. Specifically the JAK2, any of the molecules that inhibit JAK2, you will get more hematologic adverse effects. And so baricitinib specifically does show more cytopenias, whereas the JAK1 and JAK3 selective will not have as much. Oh, and I guess the voice is fading out a bit. Sorry. I'll just speak closer. Okay, we'll move on to the next slide. And we'll move on to the next slide. So this is, now we're going to talk about atopic dermatitis, specifically Dupilumab. And this is a slide which shows you that Sanofi, Genzyme, and Regeneron have done a tremendous job actually with the clinical trial program for atopic dermatitis. They've obviously investigated this in atopic dermatitis. They've also done asthma and chronic rhinosinusitis with nasal polyps. And you can see here that for atopic dermatitis, we have 3 pivotal studies with 2,119 adults. And the approval was in 2017 for adults. Also, we have one pivotal trial with 251 adolescents, and that's approved now in 2019. And then there's a pivotal trial also with 367 children, and that's going to be hopefully approved soon, but we don't have the approval yet. If you move over to the asthma, we have that the medication is not approved yet in Canada for asthma, but they did 3 pivotal trials with 2,888 patients who had asthma 12 years of age and older. In addition, there's 2 pivotal trials with 724 patients in chronic rhinosinusitis as well as nasal polyposis. So we have lots of experience in clinical trials with this molecule, not only in atopic dermatitis, but also with asthma and chronic rhinosinusitis with nasal polyposis. And then all of us dermatologists now have experience with this molecule commercially for atopic dermatitis because it's been on the market for several years now for adults and also recently for adolescents. We'll move to the next slide. So this is just an overview that shows the clinical trial program for atopic dermatitis. Over 2,700 patients have actually participated in the atopic dermatitis clinical studies. We're going to focus today's discussion on adolescents, and you can see that there was a large adolescent clinical trial performed where it was monotherapy they were using. Dupixent was done 300 milligrams, Q4 weeks subcutaneous. We'll be focusing, though, our discussion today on the second box there, which shows that the weight-based dosing of Dupixent 200 milligrams every 2 weeks subcutaneous and 300 milligrams every 2 weeks subcutaneous in less than 60 kilograms and greater than 60 kilograms respectively. And there was a placebo arm as well. So again, important to know this was a monotherapy study. In adults, there were both monotherapy and concomitant TCS studies that were done. We'll move to the next slide. And so the efficacy endpoints here, everybody here knows about many of the atopic dermatitis studies that have been done. you can see that the efficacy endpoint, primary endpoint, was actually the proportion of patients with IGA 0 or 1. So that means clear or almost clear at week 16. They also had to have a 2-point improvement in IGA from baseline. You can also see there were several additional pre-specified secondary endpoints, including the EASI-75 and change in EASI. In addition, there was peak pruritus numerical rating scale and an IGA as well at week 52. We can move to the next slide. And so this is a slide which just shows you that the patients who were enrolled in the clinical trial had significant disease burden. And many of these individuals had allergic comorbidities, and these tend to be the more difficult patients to treat. So you can see here from the adult studies that the number of individuals with IGA score of 4, the proportion was actually almost 50%. It was 48% specifically. And in the adolescent study, it was 54% of patients. So that's a high disease burden. In addition, the mean EASI score was 36 in the adolescent studies and 33 in the adult studies, which shows you that, again, the EASI score is very high. Those are difficult patients to treat. And also there was a high proportion of individuals with allergic conjunctivitis, in addition, allergic rhinitis, also asthma and food allergy. And the mean disease duration, you can see in the adolescent study, was 12 years, and in the adult studies, it was roughly 28 years. So these are patients who have high disease burden. That's something to note, because when we talk about the efficacy results, you'll see that they may not be as high as we would like, but it's because also this was a difficult population to treat. We'll move on to the next slide. And we'll move on to the next slide. So this is a slide which just shows you the efficacy data from the adolescent studies. We'll actually start on the right of the slide. So the primary endpoint, IGA 0 or 1, 24% of patients with the Dupixent dose that was based on their weight, less than 60 kilograms or 60 kilograms or greater, actually had achieved that primary endpoint at week 16. And the secondary endpoint, EASI-75, 42% of individuals achieved that endpoint at week 16. And this was significantly better than placebo, as demonstrated by the chart. In addition, more placebo patients required rescue treatment compared to Dupixent patients through 16 weeks. That was 59% versus 21%. So almost 3 times the number of patients in the placebo group versus Dupixent group required rescue treatment. And that has been my experience in real life too, is that many of these individuals are only using moisturizer and very rarely some sort of topical treatment. Most of the time, they're not doing much, actually. They're just doing their Dupixent treatment and they're super happy with it. And if you look to the left of the slide, you can see that the peak pruritus NRS score went down. There was significant improvement by week 16, and 37% of patients actually had a greater than 4-point reduction in peak pruritus NRS, which is huge, almost 7 times as much as placebo. And there was a 48% itch reduction from baseline at week 16 with Dupixent versus 19% with placebo. And that was also statistically significant. So we're seeing here that Dupixent works very well in the adolescent population, not only from an EASI-75 standpoint, from IGA 0 or 1 standpoint, but also from a peak pruritus NRS standpoint. And improvements were seen as early as week 4, 22% versus 5% if you compare Dupixent versus placebo patients. And patients in real life will tell you this too. The adolescents will say itch went away first, like very quickly. They noticed a significant improvement with itch, and then the redness and the flaking, that kind of takes a little bit extra time to subside. We'll move on to the next slide. So this is a slide which shows you the comparison between the adolescent and adult data. And it shows that if you look at the data, even though the numbers may be slightly lower in the adolescent studies, and we attribute that to a higher disease burden compared to the adult population, you can see that still, relatively speaking, the results are similar and comparable. So the IGA 0 or 1, if you compare, Dupilumab showed 24.4% at week 16 achieved that in the adolescent studies, and 37% achieved that in the adult studies. But if you do the difference between that and placebo, the difference is actually pretty similar. So it's about a 22% difference between Dupilumab and placebo in the IGA 0 or 1 category at week 16 in the adolescent studies. And it's about a 28% difference between IGA 0 or 1 in the adolescent studies versus the adult studies with respect to that. So EZ75, if you look across that row, same thing. The difference is when you calculate the difference between the medication and the placebo, it's actually relatively similar in the adolescent and adult studies. We'll move on to the next slide. And these are great photographs. So this just shows visible results in adult and adolescent patients with atopic dermatitis treated with Dupilumab. And you can see here in adult patient 1, adult patient 2, and adult patient 3, those were not clinical trial patients. Those patients were actually outside of clinical trial, but you can see tremendous results. Adult patient 1 is clear at week 16. Adult patient 2 is clear at week 16. And adult patient 3 here is clear at week 16. And then there's an adolescent patient that was from study. And that one, you can see that the IGA score went from 4 to 2. And it's a 2-point improvement in IGA. But this patient actually would not be considered achieving the primary endpoint because of the fact that the IGA score is not 0 or 1. However, at week 16, if you were to ask that patient, are you happy with your treatment? I can almost guarantee you that patient will be happy, because you can even see there are way less excoriations, there's way less erythema, there's way less lichenification. While it's not perfect, it's still significantly better. And we would just have to find out, in real life, we can use topical therapies. And so if you add a topical therapy to this, I'm sure we would get even better results. And also with Dupilumab, I think another pearl we've learned from real world experience is that it does take a little bit more time in some individuals to get that score of IGA 0 or 1, clear or almost clear. Some patients, it's taking 6 months, and some patients, it might take 9 months. I feel like atopic dermatitis is maybe a little bit more similar to hidradenitis suppurativa, where we can't assume that a medicine does not work at 3 months. We have to give it time. We have to give it 6 months, 9 months, even a year before deciding if the medicine has failed, or if we need to dose optimize, or if we need to add adjunctive therapy. So I think patience with this population is important, and focusing on the positives is very important as well, saying, compared to baseline, you're so much better. And part of the reason we do easy scores on everybody that's adolescent or adults in our practice, or even children, if they're on systemic therapies, we always do easy scores and also IGAs and body surface area calculations to show patients that, no, you know what, you are much better. Based on when you first came in, look, you're about 75, 80% better, and let's focus on that because your skin was a mess when you first came in. Let's move to the next slide. And that's just another photograph which shows you before and after 16 weeks of treatment with Dupilumab at the 200 milligram every 2 weeks. You can see that there's significant improvements. There's still some leftover lichenification, subtle erythema, subtle scale, but this individual will be very happy with their treatment. And this is an individual who did reach IGA 0 or 1, also had EZ75, EZ50, pruritus improved over 3 points, CDLQI improved over 6 points, and POEM improved over 6 points. And so that's a tremendous response. Move on to the next slide. I'll skip this one. This is just some post hoc analysis data. Just shows you that across various subgroups, of course, when we do clinical trials, there's always post hoc analyses that occur. And treatment effects in subgroups were generally consistent actually with the results in the overall adult study population. So for weight, age, gender, race, prior treatments, including systemic immunosuppressives, it seemed that Dupilumab actually works in all these individuals. And so that's great. And yes, Dr. Lind is right. Nothing better than happy patients, because happy patients means happy dermatologists. Let's go to the next slide. And this is just a slide which shows you that we cannot just base our impressions of a certain medication on clinical trial data. We know in clinical trials that the criteria are very strict. We can only use one medication, and it has to be at a certain dosing frequency. And we can use rescue therapy, but the rescue therapy sometimes impacts how we calculate efficacy data and whether that patient's considered a responder or a non-responder. And different studies have different methods of doing that. So in real life, we're seeing that, many of these patients, even though their score is significantly better, but it may not have achieved an IGA of 0 or 1 in clinical trial, these patients are still super happy because they've had a tremendous response in their EASI score. They've had a tremendous response in their pruritus. And that's what we got to focus on. So some of the adult patients not achieving primary endpoint with the IGA 0 or 1 still had like a mean percent change in peak pruritus of 35% with Dupixent versus placebo was 9%. and the percentage of patients achieving EASI-75 was still 21%, and placebo it was 5%. So it's still much better. And the mean percentage change in EASI from baseline was about 49% versus 11% in placebo, which is quite amazing. Dr. Gulliver asked a great question: where is the real world data? And I think that there are some, hopefully some registries going on. I know that there's going to be one starting, the US Corona registry that was being done. Of course, that's Corona with 2 R's, not 1 R. They're doing a psoriasis one right now, but there is going to be an atopic dermatitis one, hopefully coming out pretty soon. And I think there are some Canadian sites already selected. And so that should help us as well. And our friend Motaz here, Motown Madness, has also mentioned that there are several Sanofi-funded independent registries ongoing. So we look forward to seeing that data. But great question, Dr. Gulliver. And adolescent patients on this slide too, it shows you that even though some of these individuals did not achieve primary endpoint of IGA 0 or 1 with a 2-point improvement in score at week 16, they still had a tremendous response actually with the Dupixent. We'll move over to the next slide. And let's see here. I'm going to skip this one. It makes me depressed, so I'm just going to move on. This is another slide which shows you amazing photographs. But interestingly enough, this patient did not reach IGA 0 or 1. And the patient actually had an IGA of 2. And so even though this, if you look at the pictures, I mean, anybody would be happy with those results. When we do clinical trials, you have to go by what you see. And if they have an excoriation that is a 2, out of 3 for score, then sometimes the study criteria say that, well, if you have any 2s for any of those categories that you do your EASI score on, you have to give a mild, which means an IGA of 2, and that means the patient will not have an IGA of 0 or 1, and it means they will not reach their primary endpoint. But you can see these photographs show phenomenal response, and I'm sure everybody was happy with those results. So EASI-75 and EASI-50 were achieved here, but not IGA 0 or 1, and the CDLQI was also not over 6-point change. But the POEM score did improve over 6 points, and the pruritus score did improve over 3 points. Move over to the next slide. 17-year-old patient with atopic dermatitis, and you can see no IGA 0 or 1 achieved, and EASI-50 was not achieved. But again, the photographs look amazing. This patient's done very well, and that's only at week 16. If you're allowed to add topical therapies, and if you're allowed to keep the patient on Dupilumab longer, I think this patient would do very well, and we just got to be more patient with that individual. So again, shows you huge improvements, but if you were to use clinical trial criteria, the patient would not achieve the primary endpoint. Move over to the next slide. And another 13-year-old with atopic dermatitis for 12 years, again, looks amazing on the photographs, but did not achieve IGA score 0 or 1 or EASI-50, but you do see improvements in pruritus and CDLQI. We'll move over to the next slide. Safety data. We'll move over to the next slide. This just basically shows what we already know in the adult population. Roughly, it's about 10% of patients get conjunctivitis. That seems to be the adverse effect of special interest. And in the adult studies in particular, on this slide, it shows it was about 9% in the Dupixent versus topical corticosteroid study. And then in the adult monotherapy study, there was about 10% of patients that had conjunctivitis. And the numbers are similar actually in children. Interestingly enough, in real world, I'm not seeing that much conjunctivitis in the pediatric and adolescent population. The adolescent population, which is the main focus of this talk, I haven't had many patients with conjunctivitis, either baseline or when they went on Dupilumab, they haven't had it. And I find that I've actually had faster responses in children with Dupilumab from an efficacy standpoint. I think children respond faster. That's been my gestalt so far. And it seems that their atopic dermatitis goes away faster than in the adult population. Other side effects that can occur are listed here: injection site reactions, roughly 10%. Honestly, none of the adolescent patients I have on Dupilumab have complained about it. In fact, they've all been thrilled. And some of them were a little bit hesitant at the beginning to go on an injection. But once I told them this, listen, you're going to spend way less time, money, and effort on your skin. The parents were aboard. And in fact, the child was aboard too, because they're like, well, if I have to suck it up for 5 seconds and get an injection, that's better than spending time putting topical therapies on. And there was a study actually done that showed the mean treatment time from 2 studies applying topical therapies was 17 minutes per day in one study and 63 minutes per day in the other study. So if you could go down to 5 seconds with an injection, I think patients will take it any day. And really, we haven't had major issues. And Dr. Lind also agrees that in real world, it seems that the conjunctivitis, while it can happen, we're finding that it's not a huge issue or detriment to keeping the patient on Dupilumab and being able to manage it. Specifically, there's been some excellent manuscripts that have been written by fellow Canadian dermatologists that we've been using. My friend, Dr. Peter Leo in the United States, he's an expert in atopic dermatitis, and I do what he does. So I give loteprednol 0.5%, and we do that eye drops. That's a corticosteroid, and then we do also lubricating eye drops, and we also sometimes give omega-3 tablets for both adolescents and adults who have this issue. And I always tell them before they even start Dupilumab, it's best just to get some lubricating eye drops in advance and start using it right away, because it's not going to harm anybody. We do send patients to ophthalmology, and they've been very helpful. And so having a neighborhood ophthalmologist is very useful. And so you can always send patients to them and they can advance therapy if needed. HSV can occur. Honestly, it's been a non-issue in my adolescent patients. I haven't really had a problem. The rates are super low. You can see on this slide, they're saying that oral herpes occurs in about 3% and 4% of patients in these studies that were done. And in other herpes simplex virus infections were roughly 1% to 2%. I haven't really had any issues. They've also shown that Dupilumab reduces the number of infections overall, in terms of the skin barrier becomes intact. And so we actually are less prone to developing infections with Dupilumab, and that's been shown over many studies as well. We'll move on to the next slide. Discontinuation rates are very low due to adverse events. In the studies, the adolescent study at week 16, actually, there was 0%, which is very impressive. At adults, the concomitant TCS study, 1.8%. And in the adult monotherapy studies, it was 1.9%. So very few patients actually discontinue Dupilumab due to adverse events. And their patients are doing great. It doesn't seem to be any major issues. Move on to the next slide. The one adverse effect of special interest I should talk about before I mention this slide is that the persistent head and neck dermatitis we're seeing. So I'm not seeing much of this in the adolescent population. I am seeing it in the adult population. And there's many different theories as to why these patients get persistent head and neck dermatitis. Some thoughts are it could just be atopic dermatitis. Another thought is it could be contact dermatitis. Another thought, it could be more of a periorificial dermatitis. And then there's some thought that it could actually be rosacea of some type. Other people have mentioned certain microorganisms playing a role, for instance, Demodex mites, and also Malassezia, which is a yeast. And this has been a real problem in our adult patients, not only with Dupilumab, but I'm actually seeing the same problem, persistent head and neck dermatitis, in patients in clinical trials on oral JAK inhibitors, and even the oral JAK-SIK inhibitor that they had attempted to investigate. And we're seeing this where they completely clear everywhere else, but on the head and neck, they get this persistent dermatitis. And I agree, Dr. Lin makes a great point again. What we've been doing, I've had the most success using itraconazole, 200 milligrams once a day in adolescents and adults. If their adolescent weight is close to adults, it's fine just to give itraconazole. 200 milligrams I do once a day for 14 days and I reassess. Some patients will require 4 weeks, and some manuscripts have been published where they're actually saying do 8 weeks worth. And I do find that itraconazole has made probably the most impact on these individuals. And I even had a couple of patients I did skin biopsies on, and they actually did comment on the fact that yeast organisms were seen in the skin biopsy. So whether that's relevant or not, we're not sure. But I have found itraconazole 200 milligrams to be an excellent treatment for these individuals. I've also used non-topical corticosteroids, such as tacrolimus 0.1% ointment, and also crisaborole 2% ointment in these individuals. In addition, we've had tremendous success with something you may not know about, black tea compresses. So we're in the world of millennials. I am actually a millennial, so it's great. I'm allowed to be entitled and obnoxious and arrogant. It's really great, actually. I can basically write off everything that I do and just say, hey, I'm a millennial. It's not my fault. But the best part is that black tea compresses. You could give somebody Dupilumab and you could clear their eczema, atopic dermatitis, and they're happy, right? But when you give them something natural, they get even happier and they think you're the greatest gift to mankind. And so what we do is black tea actually has anti-inflammatory components in it. And what we tell patients is take unflavored black tea and you put boiling water into a cup, and you put the black tea bag into it. And then what you do is you let it sit for about 10 minutes, and then you actually dump out that hot water. You keep the black tea bag in that same cup, and you put more hot water into it and let it sit for about 10 to 20 minutes. And you let it go to room temperature. Once it's at room temperature, you take the tea bag out, and then you actually use either a gauze or a towel. And the patient will then put that onto the face and onto the neck area. And you can do that 4 to 5 times a day. And it's been working very well for patients. And some studies have shown even that 12 to 30% of patients had their scores drop dramatically in terms of EASI. That was a pearl from my colleague, Dr. Peter Leo in the United States. And it's been working really well. And patients have been very interested in trying this because, at this point, when they've done all these topical therapies in the past, many of them become very adverse to using topical corticosteroids at this point, and they get frustrated. And so when you give them something that's more of a natural treatment, they're all over it. And the good news is black tea compresses won't cause any problems. It's inexpensive. Everyone's got black tea in their house, or they should anyways, and they can use this. So that's a pearl that I've learned. I've been doing it in adolescents. If I've had maybe one adolescent that's had this problem, most of the patients are actually adults, and they've actually responded to this. Some great thoughts actually in the chat box. So people have noticed improvement with ketoconazole and hydrocortisone combination. There's also been the tacrolimus has been mentioned in a poster at the EADV that it's worked. The other question that I should answer before I move on is my friend John Kraft. What are the main systemic therapies I'm using in pediatric patients prior to starting Dupilumab? And how long are patients on these medications before I make a switch? Well, if I can get them on Dupilumab right away, that's always the best option. But some of these patients have actually been on methotrexate, is the number one, probably most commonly prescribed systemic therapy in North America. If you ask the Europeans, there was actually a manuscript published on this by this a panel actually from the Society of Pediatric Dermatology, the PEDRA folks, that cyclosporin is more commonly used in Europe, but in North America, it's actually methotrexate. And so I'll use methotrexate first. That's my first go-to medication. And I do a 0.5 to 0.7 milligram per kilogram. I do try to max them out because methotrexate I find works best for atopic dermatitis at those higher dosages. And some of these children have been on it anywhere between 3 months up to sometimes 5 years because we did not have Dupilumab on the market. And if we don't have Dupilumab, then I try to put them on clinical trial. So there's these patients who've been just sitting on methotrexate for years and they're only ever 80-85% better. But with Dupilumab now on the market for adolescents and these other emerging therapies being involved in clinical trials, we're able to actually now convert them and give them a more targeted approach. Cyclosporin I do use. I even have some children on methotrexate and cyclosporin, where I'll do cyclosporin at 5 milligram per kilogram divided BID, methotrexate at 0.5 to 0.7 milligram per kilogram once a week. And then once they're clear, I do either drop the cyclosporin completely, or in some individuals, I've had to do either a weekend dosing of cyclosporin and I get them to do the methotrexate on a Wednesday so that they don't get a flare up between their methotrexate doses, because sometimes that's been the problem is the families say, well, child's pretty good for a couple of days after their methotrexate, but then the problem is they end up getting a flare up. So 5 minutes left. Excellent. So we're actually doing pretty good. We're almost done. This is just a slide which shows you that patients across all ages in the clinical trials had a history of systemic corticosteroid use, which I only employ for flare management because the issue is they all have a rebound flare after you stop it. And it just showed that with Dupilumab in the studies, there was way less use of systemic corticosteroids once the patients went on Dupilumab. We'll just move on to the next slide. And these are just the adverse events, which we've already gone over everything. So I'm going to skip this. Just that conjunctivitis is there and we have to deal with it. And this was just a manuscript which showed that conjunctivitis risk factors, there's a higher baseline disease severity, longer duration of AD. I wonder if that's why we're seeing more of this in the adult population, prior medical history of conjunctivitis. And then there's some laboratory markers also that may predispose people to developing or maybe indicators that patients may get conjunctivitis. Move on to the next slide. And this is just a summary slide. So someone asked a great question. Can you transition people off of Dupilumab and maintain remission? This is probably the $1 million question. And right now, none of my patients that are adolescent and off-label pediatric have come off of Dupilumab. it's been such a game changer for them that they've stayed on drug. And in those patients, at some point, if they're clear after 6 months or a year, I tend to go to a year. I have dropped the dose. And so off-label, some of those every 2-week patients, I've gone down to every 3 weeks and said to the families, let's see what happens with every 3 weeks. Let's do that for the next 3 months. And you call if there's a flare, and we'll go back to every 2 weeks. But if there's no flare, we'll sit tight at every 3 weeks. And then we've also been able to do a few patients at every 4 weeks, because in both adults and adolescents, they've done the every 4-week dosing. It actually showed improvements. And sometimes there's no difference actually between the every 4-week and every 2-week in certain populations. And so we've been able to drop the dose, and patients have been happy with that. I have not been able to transition anybody off of Dupilumab and maintain a remission. There was one patient in my entire practice, and I have a lot of patients on Dupilumab, who came off of it because he thought that he wasn't seeing an improvement. Interestingly enough, he had a 96% improvement in his EASI score from baseline. It was just the concept of doing an injection that bothered him. And so he stopped it. And of course, he flared. And so, over the course of 6 months, his eczema basically went back to what it was before. But I think that's going to be the question long-term, is now in these children and adolescents we have, if we stop it, what proportion of patients still maintain a remission? And I think that's why we need more real-world data on that subject, and to figure out if some of these children and adolescents just do end up growing out of it, and when that is, and what laboratory markers we could have. And Dr. Gulliver is right. Takes it in the summer when he flares. Yeah, and maybe that's what we do for some patients. If it flares in the summer, take Dupilumab. If it flares in the winter, take Dupilumab. But the take-home message from this talk is that Dupilumab is available for atopic dermatitis in adolescents. My clinical experience has been these patients do better, faster than in the adult population. They have no complaints about doing the needles. There's been no issues. Even in the off-label children, I have less than 12 years of age, there's been no complaints. They've been super happy with it. And the parents have been very happy because they're spending way less time, money, and effort on their child's skin. It seems to be a win-win for everybody. And the nice part is no laboratory test monitoring. There's no interactions with immunizations. They've done studies on that showing that Dupilumab doesn't interfere with that. And of course, no increased risk of COVID-19. So really, patients are very happy with this treatment. I think that's it for me. Do we have another slide? Or is that it? Just the dosing schedule. So just to remind you folks that adults and adolescents over 60 kilograms, it's the adult dosage, basically 600 milligrams subcutaneous loading dose, then 300 milligrams every 2 weeks. And in adolescents less than 60 kilograms, this may be some new information for some of the folks that do not treat children and adolescents, just that in the adolescent population, it's 400 milligrams subcutaneous every 2 weeks if the weight is less than 60 kilograms, and then you proceed with a 200 milligram every 2-week dose. And I think that's about it for me. So if you have any questions, feel free to ask them in the chat, or you can unmute, whatever works for you.
Yeah, great talk there. That was fantastic. I think we answered a lot of the questions in the chat. I'm going to ask the audience here if there's any other questions they want answered. We've got one here from Dr. Gunther. She's asking, is there any staining with the black tea?
No concerns.
No
Haven't
concern.
had any complaints.
Okay, good. And Wayne Gulliver asked whether it was Tedley or Red Rose.
Excellent question. It's whatever they have in their house.
Okay. Wayne
Whatever's
always asks
organic.
interesting questions. We've got one here also, Dr. DeGans. The question from Dr. DeGans, Vim, is there any good economic study that is suggested by using Dupi, you're actually saving money because you don't have all these other time factors, cost of putting the cream on, etc.?
I think there actually are studies in the United States that have come out showing that this medicine can actually reduce economic burden. And hospitalizations is one. So in US and Canada, especially, like if you have to hospitalize somebody for their atopic dermatitis, that's a huge cost on the system. But that's a great point, and I think that we do need to maybe do a study where we show that the amount of money and time that patients are spending on their eczema or atopic dermatitis has gone down. I'd have to look into that actually, just to find the specific data, but perhaps I can look into that with Motaz, and we can get back to you on it.
Yep, you can send that through, and we can send it to everybody, Vim. The big thing in your talk that I think you really need to get the data out and make the pediatricians allergists and everyone in general practitioners recognize that deprivation is bad in many, many, many different ways. And it's like having a chronic disease. And if you can get them sleeping properly, that kid isn't going to be short, isn't going to have as much trouble at school, etc. And I think that's, particularly in this population, we need to think about that more.
And if I could just add some additional information. So there's actually a wealth of data when it comes to indirect healthcare costs. So things like caregiver burden, especially with parents for kids, et cetera. And that was actually taken under consideration by INES in Quebec because they look at total utility, not just direct healthcare costs. And part of the reason that they decided to approve Dupilumab. Unfortunately, CADIF only looks at direct healthcare costs where there is a little bit less data, but there's been some new stuff. So we'll get some things together and send them through Dr. Lin so everyone can see the available data. Good.
Thank you. I don't see any other questions here. We'll move on to the next talk. Thanks again, Dr. Prajapati. That was fantastic.